Hello, I'm Dr Frank Quinn, one of the doctors at IVF Australia. Welcome tonight to IVF Australia's streaming on Facebook. And I guess just a bit of background for myself. I've been sort of involved with fertility treatment for the last 25 years. Originated my treatment training in the UK. After I finished my obs and gynae, and then did work back at Royal North Shore Hospital, and then joined IVF Australia about 20 years ago. So my sort of experience is sort of vast in all areas of sort of male infertility, donor egg treatment, and polycystic ovaries and endometriosis. So I have got an interest in all areas of fertility treatment. But tonight, I guess the issue or the topic was to talk about sort of, IVF and different reasons as to, why when people are doing IVF treatment, I know it's quite specific, why those embryos may not actually implant and work. So, but I thought probably leading in, before you start talking about sort of IVF treatment or fertility treatment and why embryos may not implant, it's a really good idea to sort of go back and look at sort of normal human or mammalian fertility. Now, a lot of people may not be aware, but I guess as mammals, we're not probably the best of reproducers as far as efficiency goes. Unlike rabbits and butterflies and other sort of animals within the animal kingdom, they're involved in sort of having a lot of offspring, and as long as a male or a female survives the flood or the famine or COVID-19 or whatever, then the species keeps propagating. But with humans, it's a bit different. Humans, we've got a long adolescent period. When a mother gives birth to a child, she's got to look after that child for the next sort of 18, 20 years. So successful reproduction is really about when a mother has a child and that child then has its children, then the species gets propagated and things get carried on. So because we've got a long adolescent period, the body has been designed or evolved, depending on your belief in life, to prevent women from getting pregnant every month. So even if you have an 18-year-old, 20-year-old girl that has unprotected intercourse and she ovulates and sexes at the right time and the fallopian tubes are open, there's still probably only a 20, maybe a 25% chance that egg will fertilise and implant and result in a pregnancy, which is not, compared to other animals in the animal kingdom, it's not sort of a great odds. And the reason being is that, when a woman does get pregnant, it's a long period of gestation, and then you've got to nurture that baby for a long period of time. And obviously breastfeeding and caring and everything else is quite draining on the female body. So we're designed not for women to get pregnant very often, but when they do get pregnant, it's more likely to be a healthy baby. It's more likely to sort of, survive and, carry on to sexual maturity. So humans are a little bit different, like a lot of mammals with our form of gestation. It's hard to get pregnant, but when the female does get pregnant, then there's a fairly good chance that child then will go on and be healthy and live a productive life, as distinct from sort of other species. And one of the ways that the human body sort of does that, unfortunately, is with chromosomal abnormalities. So if you look at women who are trying to get pregnant, unfortunately, chromosome abnormalities within the egg, increase sort of exponentially as time goes on. So, and we know this when we do things like IVF. When we do IVF and we genetically test embryos, women who are 35 and get the most beautiful embryos on day 5 before they go back in, if we genetically test them, we know that about 40% of those embryos will have extra chromosomes or missing chromosomes. And obviously, that's not going to result in a healthy baby. And that's the basis of things like Down syndrome, unfortunately. And those abnormalities, unfortunately, increase about 0.5% every month. So that means from a woman who's 35, 40% of her best embryos with IVF are going to be abnormal, but it increases about 5 or 6% every year after that. And that's why with fertility treatment, unfortunately, we're very ageist. The first question we ask is, how old's the woman? How many pregnancies she's had before. And unfortunately, with all the MRI scans, the ultrasound scans, blood tests like IVF Australia with AMH levels and the likes, we unfortunately can't predict the quality of the eggs. Still our best predictor of egg quality is the age of a woman. Now, I totally understand that people may not meet their soulmate, or they're not ready, or there's other social factors coming into play. But unfortunately, as a fertility specialist, the age of the egg is the critical factor affecting the chances of getting pregnant, both naturally and with IVF. So basically, oftentimes people unfortunately don't get pregnant, and fertility is very common. About 1 in 6 couples will have some degree of issues of getting pregnant. Now, a lot of those, fortunately, by just doing a few tests or trying a bit longer or whatever, things will happen for them, which is wonderful. But for a small percentage of people, or as we get older, that percentage increases. There are quite a few people that will need, assistance or need further testing or whatever. And then oftentimes that sort of treatment that they look at is things like IVF. Now, IVF revolves around giving the woman, hormone injections to stimulate her ovaries to try and to get multiple eggs to grow. We collect those eggs, fertilise them, grow them, and then choose the best embryos to go back in. Now, I've got a question here from Julie about lifestyle factors. What lifestyle factors may affect fertility? And this is very important. Oftentimes we focus on the female and be very ageist, but there are other lifestyle factors. We know that smoking is bad for both men and women. Now, if a woman smokes, we know that her chances of getting pregnant are probably reduced when we do IVF by 40%. So nearly half implantation rates are reduced. So without a doubt, if people are having difficulties getting pregnant, I know it's hard to give up smoking, but it's going to be a major factor to try and increase their chances of getting pregnant. Now, at the recent fertility meeting that we normally have in Europe at this time of year, but unfortunately with COVID's been cancelled, there was a wonderful article that looked at men and obesity. So unfortunately, the average waist of a male at the moment is about 91 centimetres. That was about 84 centimetres 30 years ago. So we're getting bigger, we're getting fatter. But what we do know with this study is as a male increases his waist by about 10 centimetres, fertility reduces by 10%. So with a male, as they put on weight, we know that the extra temperature around the groin affects sperm quality, damages the sperm, and reduces the chances of getting pregnant. So weight is critical for both the male and female. Alcohol, men and women who smoke, the more you drink, the greater the difficulty you'll have with getting pregnant. I'm not too worried about having 1 or 2 glasses on a Friday or Saturday night, but if you're drinking every night, or if you're drinking a bottle of wine on a Friday or Saturday night, it's significantly going to reduce your chances of getting pregnant. Other factors are critical are exercise. Humans are meant to move, so you've got to keep moving. Even when you're doing fertility treatment like IVF, you've got to exercise. People who get pregnant naturally are going to the gym, they're going for a walk, they're walking their dog or whatever. You don't have to be a triathlete, you don't have to have a gym membership, you just need to keep moving. And moving is important. High impact stuff, we do sprint training and things like that. That's fantastic as well. You're not high impact like, fast sprints, relaxing, starting, all that sort of high impact stuff at the gym that they do. That's really good because it's a short workout. Skipping is a classic example of that. Skipping for sort of 10 minutes, stopping, doing a few push-ups, skipping again. It doesn't need to be, that difficult. Other lifestyle factors from a dietary point of view is things like sugar. Sugar is bad from a fertility point of view. It increases insulin resistance, which is not great. So we say to women and men, you want to have a low sugar diet and low in processed meat. So not too much ham, chorizo, salami, bacon. So my feeling is the best diet is almost like a vegetarian diet. It's got, perhaps a little bit of red meat once a week and some fish thrown in there and, some lean chicken. You need a bit of protein, but the vegetables are the main things. They increase the microbiome in the gut, the normal bacteria that's there, and that's critical for from a fertility point of view. Now, I've just had a question from Catherine. Catherine asks about the removal of superficial endometriosis and how does that affect IVF. Now, that's a great question, Catherine. We know there was a very good study many years ago in Canada that looked at women who had mild endometriosis, and they got randomised when they had their laparoscopy as to why they weren't getting pregnant. They got randomised and had mild endometriosis. It was either removed, and the other half, it wasn't removed. And they followed these people up, and over the following 6 months, the women that had the endometriosis that were removed did better. They basically had twice the pregnancy rate than those that didn't have it removed. We also know that women that do donor egg treatment, if we get donor eggs and we put them back into the woman, whether she's got endometriosis or she doesn't have endometriosis, if she's got endometriosis, unfortunately implantation rates are a little bit less. So that inflammation that occurs from endometriosis does have a little bit of a contributing factor on implanting. The problem we've got is that no one has ever done a study where with women who have had endometriosis, whether they've removed it or not removed it, before they've done IVF, what the pregnancy rates are. So in that situation, it's difficult to be 100 conclusive about it all. But my gut feeling is that if people have got symptoms of endometriosis, which are typically things like spotting before their period, painful intercourse, or if their periods are becoming heavier or more painful in recent years, then that suggests that they've probably got endometriosis. It may not be, their doctor should chat to them about whether they do a laparoscopy or not. And in that situation, to remove it is not necessarily, it is probably a good thing. Certainly in my practice, if I see people who have got severe endometriosis and they're not getting pregnant, then obviously one of the factors that I'm looking at as to why they're not getting pregnant is the activity, the inflammation of endometriosis in the pelvis and how we may be able to reduce that inflammation. Now that may happen surgically or it may happen basically by treating it medically by giving people injections like Zoladex and things like that. So chocolate cyst, another question here from Zoe. Sorry, there's a few questions coming through. I apologise, I'm a bit slow with Facebook. Zoe, your question about extreme endometriosis and chocolate cysts, do you remove them or do you not? Very good study. It really depends. You can have a solitary cyst in the ovary, and that has, the tubes are normally mobile, everything else is okay. And we know that removing that cyst prior to IVF probably makes no difference at all to the outcome of IVF. But for me, if someone's got a chocolate cyst, I'm thinking about whether there are, more endometriosis in the pelvis, other tubes stuck down, and whether that may affect their fertility. But if a woman's got a solitary chocolate cyst, then I would sort of say there's probably no need to remove that prior to IVF. You would remove it if it's causing pain or other issues or whatever. But you've also got to remember the backbone of IVF is to stimulate the ovaries and get multiple eggs. We want to give the scientists, half a dozen eggs or whatever to work with to find the best embryo in the batch to put back in. When we operate on the ovary, we may be compromising egg numbers. And if we're reducing egg numbers that we give to the scientist, then that's going to lessen the chances of things like IVF working. So it's an individual decision, personalised decision depending on how bad the endometriosis is, the age of the woman, her egg reserve and things like that. But not necessarily would you need to remove it. Liz asked a question, how long does a day 5 frozen embryo should be stored? She's got a 4-year-old from a frozen embryo and planning a transfer. Now Liz, with the embryos don't deteriorate with age. Your chances of getting pregnant are the age of the egg that it was frozen at. So if you were 32 when you froze that egg, then basically if you put it back in when you're 38, you've got the same chances of 32-year-old. So it doesn't deteriorate with age. The only downside is if you've got one embryo there and it doesn't work and then you need to do another cycle, then you're going to be a little bit older, but the egg doesn't deteriorate, and so basically, I would carry on with that. Another question from Cassandra asks, when it comes time to the transfer of an embryo, would you recommend it transferring 1 or 2 in a healthy 32-year-old, and why? Great question, Cassandra. My advice is if you were coming through IVF Australia and you're 32 and it was your first or second embryo transfer, it would be a no-brainer. We would only put 1 embryo back in. If you put 2 embryos back in, it increases your chances of twins, and twins have a much higher, IVF twins have a much higher instance of premature labour, and with premature labour comes an increased instance of cerebral palsy and developmental delay. If you've got good embryos, put 1 in, freeze the others, and you get 2 bites at the cherry. If you do get pregnant, come back later on, you've got a much better chance of having a healthy family at the end of the day. With twins, in addition to things like hemorrhoids and heartburn and stretch marks and morning sickness, they're all increased, high blood pressure, diabetes, but also social factors like divorce is greater, postnatal depression is greater. So if you're 32 and it's early on in your journey with IVF, my recommendation is if you're going to having treatment at a good laboratory, and at 32 pregnancy rates are probably in the 40s, I would stick with just 1 embryo. Sam Benson talks about being a cancer survivor and expected to go into early menopause, and so she's been freezing eggs, and would her chances remain the same as an average woman by my natural age when facing menopause? So Sam, depending on what happens with your egg numbers, so if you have a good AMH level and you are, 35, and you had a lot of eggs collected, your chances of getting pregnant are going to be related to the age that you froze those eggs. So I'm not too worried. There's a lot of studies that show now that women that have been through cancer treatment don't appear to have a significant reduction in their pregnancy rates. If you try and get pregnant, 3 or 6 months after chemotherapy, and it depends on what cancer treatment you've had, that will influence things. But if you've been off chemotherapy for 6 or 12 months, then the chances of getting pregnant will be really related to your age. Now, I say to women, if you're less than 35, freezing eggs, pregnancy rates are probably about 2 or 3% per egg that you freeze. And as you get older, unfortunately, that number probably drops down to 1 or 2%. So freezing eggs, the younger you are, again, because of chromosomal abnormalities, is the critical factor. Violet sort of regarding embryo implantation. So, sorry, I'll scroll back, Violet. Here we go. Violet says, I'm having my first embryo transfer next week. Any tips regarding activity levels at this time with regards to movement, sleep and diet? And what evidence is there of lying horizontal for the first 48 hours? Great question, Violet. My advice is carry on normally. When I first started doing this a long time ago, when we did IVF, we used to do the embryo transfer, and women would have to stay in hospital overnight after their embryo transfer. Now, basically what happened was there were some women that would sort of say, look, if I don't get up and go to work, I would lose my job. And we follow those women up, and it made no difference. Now, women who get pregnant naturally, they don't know that the egg has just dropped down from the fallopian tube into the uterus at that particular time. They might be training for a triathlon. They might be doing sort of, playing comp tennis or whatever, running, being very busy, stressed out or whatever. My advice is at the end of the day, exercise is good. You go outside, you go for a run, you walk or whatever, it releases the endorphins, it reduces your stress hormones, you sleep better, it's critical. Sleep is a good thing. You want to be in a regular sleep pattern. We know that people that have insomnia or don't sleep very well have higher blood pressure and things like that. So eat healthily, a low sugar diet, don't smoke, avoid the alcohol, have a regular sleep pattern, but don't feel guilty. If you've got a dog and you want to take the dog for a walk or go for a 5K run or whatever, then do it. I wouldn't do anything too strenuous or too heavy like weight bearing, because also at the end of the day, if you're doing IVF, you've spent a lot of money, time and emotional investment in it all. And if you're not pregnant, unfortunately, you don't want to look back and say, oh, I shouldn't have done this or I shouldn't have done that. So in that situation, you need to sort of weigh it up. Now, I know a lot of my colleagues that do treatment in America, when they put embryos back in, they tell people to lie in bed and do nothing for the next 2 or 3 days. It doesn't make any difference, trust me. So you just need to, have the day off for your transfer, relax, but I still think it's a good thing to move around. Okay, I'll scroll through a few of the other questions. Here we go. Anna sort of says, I'm not having success with IVF. Do you recommend IUI? And she's 41, doing fertility treatment with donor sperm. Now, I would Anna, great question. I would sort of look at that and sort of say, well, how many IVF cycles have you done? Whether there are any other issues going on in your situation. So, what's the quality of the embryos like that you're putting back into the uterus? At IVFA, when we grow the embryos in the embryoscopes, there's artificial intelligence that looks with the time-lapse photography when the embryos divide and how they divide. And from that, it compares them to thousands of other embryos and can tell people, the likelihood of an implantation. So that sort of thing's good because, unfortunately, if people have embryos that are giving scores of, 5 or 10%, then that may influence whether they carry on with the treatment or not. It also depends on how many eggs you're getting and fertilising and things like that. So if someone's doing IVF and they're 41 and only getting 1 or 2 eggs, then definitely IVF, the backbone of it is giving the scientist multiple eggs to find a good embryo to put back in. If you're only giving the scientist 1 or 2 eggs, then IUI probably will give you the same chances of getting pregnant. That makes a couple of assumptions. It assumes that the sperm is good. It assumes that your fallopian tubes are functioning normally. And it also assumes that inside the uterus is good. So if you've done a couple of cycles at IVF and you're not getting pregnant, I'd be sort of thinking, well, what's happening with the uterus? Is there any polyps in the uterus? Is there an infection there? Do you need a hysteroscopy where they have a look inside and do a little biopsy and check that the lining of the womb is all good and there's nothing stopping the embryo from implanting? But also the stimulation, what drugs you're on, what the quality of the embryos are like. They're the sort of things that come into play. So it's difficult to sort of give you an easy answer, but those sort of things need to be addressed individually. Another question: used to exercise a lot. Haven't been doing a lot of regular exercise for approximately 6 months because of, unfortunately, her mother passing away, which impacted on a regular routine. If I start exercising now, how long do I have to exercise before seeing positive effects? you see positive effects almost immediately within a week. So depending on what exercise you did before, it just needs to be titrated to that. So if you do Pilates or if you go for a walk, you can do that straight away. Obviously, if you were running half marathons, 6 months ago, you're not going to go back to be running, 10 or 15 Ks overnight. You've got to gradually increase it back up. But your body benefits from those sort of things almost immediately. I know if I do exercise and I don't consume alcohol, my resting heart rate is like 48. And if I don't do exercise and I have a glass of wine on a Friday night, my resting heart rate's 56. So the body responds fairly quickly to it, and you will get benefits from it within a week. And even after you do exercise, you feel better that day. You sleep better. The impacts are almost immediate, but obviously with regular exercise, it's good. It keeps the weight off. It lowers the insulin levels and improves fertility treatment. Jessica asked the questions, how long can an unfertilised frozen egg be lasted? Had 4 eggs frozen 4 years ago. Again, they will not deteriorate with age. So once they're frozen, whether you thaw them out today or whether you thaw them out in 5 years' time, it doesn't make a difference. And if it came to the situation where, unfortunately, people need to consider surrogacy, the age of the surrogate and the age of the egg don't have an impact on your chances of getting pregnant. So it's really the age of the egg which is the critical factor affecting the chances of implantation. And we know this when we do things like donor egg. Unfortunately, we've got lots of patients, they're in their mid-40s that would be desperate to try and get pregnant. They don't have very many eggs. They've got a low ovarian reserve or poor egg quality. And when they go through fertility treatment, sometimes they will explore donor egg. And we know if we take the egg from a 25-year-old or 30-year-old, say 30-year-old, fertilise it with their partner's sperm or donor sperm, grow it in the laboratory and put it back into a 45-year-old woman's uterus, the chance of getting pregnant is about the same as that 30-year-old egg. So the egg makes up like 98% of the variables as to whether there's going to be implantation. The uterus is important, the sperm is important as well, but they have a smaller impact to play on things. So the age of the egg is critical, and the good thing is, with vitrification and freezing embryos now and eggs now, they don't deteriorate with age, which is absolutely fantastic. And also now, like when I first started doing fertility treatment, when we froze embryos, for example, probably about 15% of embryos we thawed out didn't survive, that were sort of lost in the process. So that's a huge, 1 in 6 was a huge attrition rate. Now at IVFA, when we freeze eggs, we probably have about 2 or 3% of eggs or embryos that don't survive the freeze-thawing process, which is fantastic. So what eggs that you've been frozen and embryos have been frozen, you maximise your chances. Question here from Dino. Dino says his wife had an early miscarriage this month and continued for next transfer. Any suggestions for success of getting pregnant with regards to activity and food? On that question, Dino, the first thing is with most miscarriages, depending on the age of the woman, a lot of them, unfortunately, are chromosomal abnormalities. We know from research a lot of embryos, the embryo's got an extra chromosome or missing a chromosome, and it's not compatible with life. The embryo has a wonderful way of checking its DNA to make sure it's got the right amount of DNA in there to result in a healthy baby. And if it doesn't, it shuts down cell division. It stops itself from dividing and then stops the embryo from growing to minimise the chance of a woman going on and having an unhealthy child or a handicapped child. So it's not anything that she could have done or prevented. It's unfortunately one of those issues of fertility. Now, saying that, it's incredibly stressful going through miscarriages, and I empathise with her, and she'll have that with her forever, unfortunately. The pain will hopefully diminish as time goes on. but I would say that hopefully the important thing is to try not to feel guilty about it. A lot of these factors are out of our hands. Again, as far as activity goes, there was one study in the UK or the Nordic countries that looked at women who were doing very, very heavy exercise around the time of implantation. Basically, you almost need to be an Olympic weightlifter for exercise to have a negative effect on implantation. So going about your normal daily duties, caring for an elderly parent, carrying the shopping to the car and to the house and things like that, is not going to cause a miscarriage. So quite safely can carry on normally and not feel guilty about doing things like that. I mean, obviously, when people spend a lot of money doing fertility treatment and they invest the time and the effort, some people will say, okay, for the first 48 hours afterwards, I might take it a little bit easier. Just from a mental health point of view, there's no evidence it's going to make any difference. But if that gives you reassurance that you're maximising your chances, then I would recommend doing it just to put your mind at rest and feel like you're giving it the best shot. Kelsey sort of says, is it possible to have a successful transfer with a lining of 7.7 millimetres? Definitely, Kelsey, definitely. So when we do fertility treatment and we look at implantation, one of the factors that we look at, the egg is important, but also the lining of the womb. So when we do an ultrasound, we measure the endometrium before the embryo goes back in, checking to see if it's incredibly thin or not. Now, basically, we know if the endometrium is very thin, like 4 or 5 millimetres, significantly pregnancy rates drop. But endometriums around about 6.5, 7 millimetres will oftentimes give you exactly the same pregnancy rate as an endometrium of 8 millimetres. It also needs to be taken into consideration with how big and tall you are. So if you're, for example, an Asian woman that's 5'6" and very slim, then obviously you're going to have a smaller uterus and the lining of the womb is going to be a lot thinner compared to sort of perhaps an Afro-Caribbean woman who is, 6'2". Her uterus is obviously going to be significantly bigger, and then you would expect the endometrium to be thinner. So it needs to be taken into consideration, but an endometrium, if it's 7.7 millimetres, then I don't see that as a major impact on the embryo implanting. Mandil asks the question about low progesterone. Does a low progesterone or frozen embryo transfer, will this affect implantation? It probably depends, Mandil, how low the progesterone level is, and basically within the cycle. So all I can say is that if with my patients, when we're doing frozen embryo transfers, the two ways to do them as part of a natural cycle: do blood tests, work out when ovulation occurs, and then basically after ovulation, we supplement things with a little bit of progesterone. And I normally check the progesterone level a couple of days before we're going to thaw the embryo out and pop it back in. Now, a progesterone level of less than 15 nanomoles per litre, a couple of days before implantation, is basically, I'm concerned that there may not be enough progesterone there to help with the changes that occur within the endometrium. Progesterone makes the endometrium glandular and thick and lush and allows the embryo to implant. So in that situation, if it's very thin, and it really depends on your particular situation, then if the progesterone is low, then sometimes I would cancel a cycle, not thaw the embryo out, and then perhaps try a medicated cycle or try different forms of luteal supplementation before putting the embryo back in. I guess the issue is how low the progesterone is. If the progesterone is 27, a day or two before transfer, then that's absolutely fine. a lot of people's progesterones, it's nice if it's over 30 nanomoles before it goes back in. But it also depends on what treatment you're doing and what progesterone you're on. And, you know, for some people, they will have lowish progesterone levels. A question here from Cassie. Cassie sort of says, we have 3 egg collections with 1 out of 6 eggs fertilising with ICSI on 2 occasions. One time we got 7 out of 9, which was great, related to male factor infertility. But even with ICSI, have had poor fertilisation and both 27. So obviously quite young. So in that sort of situation, Cassie, I guess it sort of comes down to how the issue with the sperm count, the sperm, how bad the male factor infertility is. So sometimes people have chromosomal abnormalities, and you've got to get a testicular sperm, and you're struggling to sort of find half a dozen, you know, twitching or motile sperm to inject into the eggs. Now, in that, you know, difficult situation, you will definitely get lower pregnancy rates, lower fertilisation rates, not pregnancy rates, to do with the sperm that you're injecting. If your partner's got a sperm count of like 10 million sperm per mil and 15% motility, then that's a different situation. Yes, you probably would expect the fertilisation rate to be greater. In that situation, I'd go back to square one. I'd be sort of saying, well, okay, for such a young woman with young eggs and the fertilisation rate being at that sort of level, then, you know, what's going on with the sperm? You know, do you need to do a sperm DNA fragmentation test to look at the quality of the sperm? You know, there are other issues sort of going on. 7 out of 9 eggs fertilising is absolutely fine. That's fantastic. 1 out of 6 is obviously low, but sometimes it can come down to that particular batch of eggs. The other thing that can happen is with the 6 eggs, sometimes, I guess, I would look at the embryology data, because sometimes some of the eggs are immature and they can't be fertilised, or sometimes they degenerate or die after the ICSI procedure. So that's quite a complex question that oftentimes needs a sort of a close analysis of what's happening with regards to the stimulation, how big the follicles were at the time of the egg collection, what the hormone levels were on, what drugs you're on, how the eggs were, how mature they were, and then going from there. So it's very difficult to sort of give advice via Facebook that way. But the thing is, you're young, you've had good success, and I find this, I mean, I've had patients where, you know, you do a cycle and you might get 12 eggs and 1 or 2 fertilise, and it happens again, and then they do a 3rd or a 4th cycle and it's completely different. So my feeling is that, you know, I think that, you know, when things don't go smoothly, it's probably good to have a bit of a time out, regroup, you know, reassess things rather than just getting on the treadmill and just doing another cycle. Go back and look at all the factors as to what's happening with the sperm, what's happening with the stimulation, what's happening with the laboratory, and what can we do to try and improve things. John's asked a question as to, does a male's age have any effect on his fertility, and at what stage does it decline? So, fantastic question, John. Yes, it does, unfortunately. You know, you hear about men that are 75 and 80 that father children and things like that. It does happen. The issue with male fertility is it is reduced probably less than a woman's eggs do. So if you look at a woman trying to get pregnant, when she's 30 and she gets pregnant, the risk of things like Down syndrome is probably 1 in several thousand, and by the time she gets to 40, it's probably, you know, 1 in 90. So in a 10-year period of time, the risk of having sort of a Down syndrome baby has increased tenfold, unfortunately. With men, as men get older, their fertility declines, and the risk to the offspring also has an effect. So we know that men that are 65 the chances of them having children with Alport syndrome, which is a kidney disease, with achondroplasia, which is dwarfism, schizophrenia, autism, all those things increase. Now, they may be increased by 10 or 15 fold, but they're probably increased by 10 or 15 fold over the period of sort of 20 or over the period of sort of 30 or 40 years. So yes, men's sperm does deteriorate with age, unfortunately, but it probably doesn't deteriorate quite as quickly as the eggs. And part of that is probably because women are born with all their eggs at birth, and when a woman gets to 35 or 40, those eggs have been exposed to sort of herbicides, pesticides, passive smoking, alcohol, radiation, Wi-Fi, BPA, whatever it is in the environment that's affecting the quality of the eggs. Whereas the men are constantly producing sperm, admittedly, as we get older, not as efficiently as when we were a teenager, but the quality of the sperm does decrease. I'll just go back to a few other questions. Okay, Michelle asked the question about how long should I keep on progesterone after doing a 3-day FET? I've heard it's good idea to stay on progesterone until 12 weeks into the pregnancy, until the placenta has formed. A very good question. Michelle, if you don't have any history of recurrent miscarriage, then most people don't need progesterone. So there was a very good study called the PROMISE trial that looked at women that had recurrent miscarriages in the UK. Half of them had placebo, half of them had progesterone, and these were women that had sort of 3 or 4 miscarriages in the past, and adding in vaginal progesterone didn't appear to reduce their chances of having a subsequent miscarriage. So the issue is that I think that progesterone is probably the symptom of the problem, not the cause of the problem. And what I mean by that is if you've got a good embryo that's implanting and producing HCG, it's stimulating the corpus luteum to produce estrogen. The corpus luteum is that follicle that's released the egg and produces your progesterone. So it will produce that progesterone and it will be fine. If your progesterone level is low, it's probably because the embryo quality is poor, it's not stimulating the corpus luteum, and it's a symptom that things are not quite right. And we notice this with IVF. When women have their first pregnancy test, if their progesterone level is low and they've been on progesterone supplementation, unfortunately we know that the risk of them having a miscarriage, unfortunately, is a bit higher. So the problem with progesterone is when I first started doing IVF in a frozen embryo transfer, and you've got to distinguish between fresh and frozen. If it's fresh, you've always got to be on progesterone, at least up until your pregnancy test. Whether you take it longer or not becomes an individual decision. But most people probably don't need progesterone after they have a positive pregnancy test. In a frozen cycle, when you've ovulated, if it's a natural cycle and you've ovulated and you've got a good progesterone level before you put the embryo back in, and you've got a good progesterone level at the time of your pregnancy rate, then adding supplementary progesterone in is probably not going to affect the outcome of the pregnancy. I know that there's a lot of women that take it because oftentimes with blogs or their girlfriend or someone in the office or their sister's taken it or whatever after they've had no luck or they've had a couple of miscarriages. But the research seems to suggest it probably doesn't have a big impact. Now, I totally understand if people have had 3 or 4 miscarriages, you want to do something different, and for the sake of taking some additional progesterone that probably has some fairly low side effects is something that people will probably want to take. But for the vast majority of people, when we put them on that progesterone, they probably don't need to take it. Now, Miranda asks a question about how will blood testing work now it will be done in the clinics. Now, I'm not so sure about that question, Miranda, how it will be done in the clinics. So, certainly at IVF Australia, we do all of our hormone testing in-house. So if people are doing IVF or inseminations or frozen embryo transfers or ovulation induction, when we take the blood and the ultrasounds, we take the blood, and we do them in-house. Probably the biggest thing at the moment with COVID-19 is the social distancing. So when people come into the clinic for their blood tests, we, from next week, will be asking them to wear a mask. And if they don't have a mask, then we'll actually give them a mask when they come into the clinic. When they come in, we'd obviously prefer their family and partners not to come in after having a blood test. It's just with the more people there, it's harder to do the social distancing. Obviously, if it's a doctor's appointment or if it's an embryo transfer or procedure, then the partner's more than welcome to come along. But the blood tests still carry on normally at IVFA. Another question here from Joy. Can I take melatonin when I'm IVF? You can. Melatonin is one of those medications where a lot of people take it in the hope that it may improve oocyte or egg quality. The evidence for it is a little bit grey, but melatonin, is largely sort of side effect free. People don't get side effects. You take it at night time, probably will help you sleep. People take 2, 3, 4 milligrams of it. Usually, though, if you're taking it to try and improve egg quality, eggs take about 3 months to grow and mature. So the eggs that start sort of growing now don't sort of get to the stage of ovulation until about 3 months later. So if people are taking treatment like melatonin or DHEA or whatever, testosterone or whatever, to try and improve oocyte quality, you really need to be on it for probably about 3 months before you're going to dramatically see an improvement. But if you're on the IVF, melatonin, take it, it's fine. Other drugs like the testosterone and the DHEA, they're completely different. They are androgens, they can increase the progesterone level, and if you increase your progesterone level prematurely, then that can have a negative effect on the lining of the womb and put the lining of the womb out of sync. So you might have these beautiful embryos, but then the lining of the womb is out of sync. Now, another question here from Afshan, who asks the question, hi, can I take clomiphene citrate even if an ultrasound shows good follicles? That question really depends on the size of the follicles on the ultrasound. So if a woman is ovulating, basically what happens is if she has a good follicle at like 18 millimeters when she ovulates, taking things like Clomid and things like that won't make a difference. There's a very good study that looked at women who are ovulating that took fertility tablets like Clomid. Clomid is an anti-estrogen. It affects the lining of the womb and can make the lining of the womb thinner. It can make the cervical mucus a little bit thicker because it's an anti-estrogen and it has quite a long half-life in the body. So if a woman's not ovulating, then Clomid's fantastic. It will release the egg, it will help ovulation occur, it'll help people get pregnant. But if a woman's already ovulating, taking it to try and get a second or a third egg is not going to make a difference. So if you're already ovulating and got a regular menstrual cycle and you're having timed intercourse, then I would question that clomiphene citrate is not going to give you a better chance. So if the follicles are small, like polycystic ovaries, 8 or 10 millimeters, and you're not ovulating, Clomid is the way to go, or letrozole. But if you're already ovulating, then Clomids probably won't help. Another question from Miranda about what sort of simple supplements can people take to improve egg quality. Now, I will declare my interests here, Miranda. I'm not big on taking supplements. You're far better off eating the berries, eating the orange that's got the vitamin C, the zinc, the fibre in it, all the other essential micronutrients that are going to help you rather than taking a vitamin C tablet. So the usual advice is it's quite simple. You can't reverse your age. You are what you are, and that's fine. But what you can do is don't smoke, don't drink too much alcohol, 1 or 2 glasses maximum on a Friday or Saturday night. Minimise your alcohol intake. Stay active. have a diet that's high in vegetables, a diet that's low in sugar, high in vegetables, low in processed meat, which is good for the microbiome, and move. So do exercise and have your optimal body mass index. And if you're doing that and you're having regular sleep, then really you're doing as much as you can. Then all the other factors, don't beat yourself up. All these other factors are out of your hands. And in view of that, you just got to sit back and sort of, leave it up to sort of Mother Nature. So, it's common sense. Certainly from a fertility point of view or trying to get pregnant, the big important things are you want to take folic acid and you want to take iodine. They're the two crucial factors. If you're not anemic, then you probably don't need to take iodine. I know people take Blackmores and Elevate and things like that, but if you've got a healthy diet, then taking iodine and folate, ifolate is probably the bare minimum that you need. But if you want to take those other multivitamins, then go for it. But you don't need to take sort of mega doses of multivitamins. There was actually a very, very good study many years ago that looked at women that took massive doses of folic acid and B12. And oddly enough, it actually showed that if their blood levels were through the roof, it actually increased the risk of autism. So the attitude of, 1 milligram is good, perhaps 10 milligrams is even better, is not the case for medicine. It's sort of, you need to take enough to be healthy, but taking mega doses of supplements is probably not a great thing. Another question is, what about inguinal hernias for Afshan in men? Inguinal hernias, if they're small, are probably not a factor. If they're large, the issue really comes down to the size and temperature and mobility and things like that. The reason that the testicles are in the scrotum is to keep them cooler. Spermatogenesis works best when the testes are about 1 degree cooler than the core temperature, and that's why they're outside the body. And that's the problem when men get overweight. When men are overweight, they've got that abdominal fat apron, they've got big thighs, there's less airflow, and there's a lot more temperature around the scrotum, and it makes it a lot more difficult to keep the testicles cool, and therefore it reduces the optimal temperature for spermatogenesis. So if there's a large hernia, particularly if it's running down into the scrotum, then that can have an effect on fertility if it's a large hernia. The other thing also is if men have got hernias and it's painful, or if they cough or sneeze, then sometimes it sort of puts them off exercise. They don't want to strain, or they don't want to run, or whatever. And then the concern there is that if they're inactive, it adds to the weight and things like that. So sometimes that needs to be reviewed by their GP or by their fertility specialist, and whether that needs to be removed or operated on. Cassie asked a question. My specialist suggested adding Livius to my 4th stimulated cycle, even though my LH levels have been good. Can Livius help with egg quality? Very good question, Cassie. We really don't know. If your LH levels are good, then probably adding Livius in. You want to try something different. You don't want to just do the same old every time and hope for a different outcome. So I think it's good to try something that's different. But the background of it, in the early days, the pharmaceutical companies developed recombinant FSH to stimulate the ovaries. LH development was very expensive, and it came around, about 10 years later. For many a year, the pharma companies have been trying to find a reason as to why LH may be beneficial in fertility treatment. Now, we know if women have got very low LH levels, or men have got very low LH levels, then if we add in LH to FSH levels, then that may be, that's definitely beneficial, and it's worth doing. Now, for women over 38 or in their 40s, there have been some studies that have suggested maybe it might be beneficial, maybe not. But you can understand, look, if there was really, really good evidence that Livius was going to dramatically increase your chances of egg quality, we would put everyone on Livius on their first IVF treatment cycle. So my feeling is that, if you're doing your fourth cycle, definitely, give it a shot. It's not going to do any harm. It's quite physiological. It's got a short half-life. So I do the same thing. I chat to patients and sort of say, well, look, we need a bit of a circuit breaker. Let's change up the stimulation, because if occasionally you're surprised. Occasionally people will have a different response to the drugs that you're not really expecting, and they'll get better quality embryos and get pregnant. So, good luck with that one. A question from Kelsey here. Kelsey asked a question, so is there no point trying Clomid again if I have a thin lining with my issues previously? I'm on 20 milligrams of Propanova daily. Probably, Kelsey, it really probably depends on how thin the lining of the womb is. If the lining of the womb is 7 millimeters, I'm not too worried about that. If you're young and you're ovulating and you've only tried it for 1 or 2 months, then that's fine. You've got nothing to lose to give it a couple of tries. But if the lining of your womb is 4.5 or 5 millimeters and you've tried it for 4 months, you've given it a good shot. It's not to say it can't work, but it's not going to be working at its most effective, and maybe it's worth considering other options, like letrozole or FSH injections or inseminations or something like that. So it really comes down to a couple of factors as to how many months you've tried it for, your age and other sort of variables as well. But certainly, if you've tried it for 4 or 5 months and you're consistently getting a thin endometrium, then I would consider other options. Definitely, if you don't want to do those other options, adding in drugs like Propanova, estrogen medication, fantastic. You've got to try and consider those sort of scenarios as well. Now, Rainbow Joy asks a question about a long protocol. So with IVF, there's sort of 2 protocols. There's that short protocol where a woman gets a period, comes in on day 2, has a blood test, and we start up the FSH injections to stimulate the ovaries to collect the eggs. Now, that's what they call a short cycle. Oftentimes, most people, that's what we do. It's short, it's quick, it has less side effects, less appointments to the clinic, and it's a lot more tolerable. So most people these days oftentimes do what they call an antagonist cycle. The long cycle is where we put people on leucorin injections or a Cinderella nasal spray that typically starts about a week before the woman's period's due. The reason it starts a week before the period's due is it takes about 7 days to work. So what it does is it turns off the pituitary's release of gonadotrophin. So GnRH releasing hormone is a hormone from the pituitary, from the hypothalamic gland that talks to the pituitary. And when you take it twice a day, it stops the body from releasing LH, so it stops ovulation. So you start at about a week before the period. Now, that's an alternative. That was what we used to do before GnRH antagonists were around. Now, is it better or is it worse? Really, they're probably very similar. But again, if someone is doing an IVF cycle and they're not getting very many eggs, or the quality of the eggs is poor or whatever, then you don't want to do the same thing. You want to mix it up. You want to try the nasal spray. One of the advantages of the nasal spray is it suppresses the cycle down. So then when the woman gets a period and she adds in the FSH injections, all the follicles are at the same sort of starting point, ready to respond to the FSH stimulation. When you do an antagonist cycle, basically what happens is eggs sometimes, if women have got a low ovarian reserve, basically have started growing a couple of days, 4 or 5 days before the woman's period's due. If she doesn't have a lot of eggs, the body's starting to get things growing in preparation for it. And then when she gets a period and we add in the FSH injections, some of those follicles may have a head start. And if they've had a head start, then when we add the injections in, they grow a bit quicker at the expense of new ones coming through. So the nasal spray is just a different way of trying to stimulate the ovaries. And if you've tried the antagonist cycle and haven't had a great response with egg numbers or embryo development, then definitely doing the long cycle with the Leukerin injections or the Cineral nasal spray is definitely worth considering. So I'd definitely try that, Rainbow. Another question from Kin Meg. Kin Meg asked a question about, can women over 40 have IUI treatment if they still ovulate normally? Yes, they can. So IUI treatment is basically along the lines where what you do is you can do it in two ways. You can do a natural cycle where you monitor the woman's cycle, wait for an egg to grow. When there's a good egg there, trigger off ovulation, and then get the sperm and put it into the uterus and see how you go. The other option oftentimes we do is we give women FSH injections to stimulate their ovaries to try and get their hormone levels higher and maybe get more than one egg to grow. And then when the eggs are ready, trigger injection and then put the sperm in. Now when we do IUI, basically with the injections, the main risk with the injections is multiple pregnancy. You may get more than one egg to grow. When you give injections, it's difficult just to get one egg to grow or two eggs to grow or nothing. Oftentimes you might have a follicle that's 14 millimetres, another one that's sort of 16 millimetres, and another one that's like 21. So you can have a cluster of eggs that are growing, and then with that comes the risk of multiple pregnancies. So if you're on injections doing IUI, that's the main side effect that you need to be aware of. Really, the question about IUI for a woman in her 40s is why is the reason for doing it. So if there's an issue, for example, if it's a heterosexual couple and the couple are working busy lives and they're not having intercourse frequently, or if the male has issues with erection or ejaculation, or fly in, fly out, not around at the right time, or if the male's sperm count, he's got really good swimmers, fantastic progressive motility, but the count's a little bit low, it's reduced a little bit, then in that situation, by us getting the sperm, prepping it up, extracting the best swimmers, placing it high, close to the egg at the right time is going to work really well. You know, that's worth considering as a treatment option. But if the woman has a regular 28-day cycle, she knows that she's ovulating on day 13 or 14, she's having regular intercourse from day 9 to 15, her partner's sperm count is good, her tubes are open, then IUI for a woman in her 40s is probably not going to be dramatically better than trying naturally. It's definitely an option because not everyone wants to do IVF and have injections and have an anaesthetic to collect the egg. So it's definitely an option there. It's a very individual decision to make. But just because you're over 40 doesn't mean that IUI is not up for consideration. The other classic situation is same-sex couples or single women that are using donor sperm that have never tried before. They may have good eggs, and once you get that sperm and put it into the uterus just prior to ovulation, you know, they do very well. They don't need to do, you know, expensive fertility treatments like IVF. So Rainbow, I guess, asked the question about, unfortunately, she's had a couple of 5 IVF success cycles, but her husband has a balanced translocation. So Rainbow, definitely in your situation, that makes it a lot more difficult to treat. A balanced translocation, for those of you may not be aware, we've got 46 chromosomes, 1 to 22, 2 lots of chromosomes, 1 to 22, XX if you're a female, XY if you're a male. So basically what happens is you can get a little bit of one chromosome crossed over onto another chromosome. As an individual, you've got all the genes and all the DNA there to be a healthy person. But the problem is at the time of fertilisation, because perhaps a little bit of chromosome 13 is on 14 and 14 is on 13, when the sperm comes into the egg, or the egg comes, you know, vice versa, then what happens is it can become unbalanced. You get a little bit of too much of 13 and not enough of 14, or vice versa. And if that's the case, depending on the size of the balanced translocation, if there's too much DNA or not enough DNA within those particular chromosomes, the embryos realise that that's not normal and they stop growing. And so it becomes very difficult. It becomes, weeding out those abnormal embryos to try and find a good one there can be a bit difficult. And poor old Rainbow, when she did the PGS, the testing of the embryos, unfortunately, had 2 embryos tested that came back with trisomy 17 and trisomy 21. But basically they are, just purely a chance phenomena related to the quality of the eggs at the time. And so each cycle is different. The fact that you're getting embryos to test, the fact that you, unfortunately had those abnormal ones, for me, I wouldn't stop trying. There's still hope there. Getting embryos to test, and it's just, as humans, unfortunately, those chromosomal abnormalities do occur, and hopefully things will improve. Another question here for Afsan, who asked a question about what is regular intercourse. So for the purposes of intercourse and trying to get pregnant, sperm will last in the female reproductive tract for 2 days, no problems. So people say, do they have intercourse every day, or do they have intercourse every 2 days? Now, my advice is, as long as you're having intercourse every 2 days, that's absolutely fine. If it's more than that, good luck to you. But you don't want to put too much pressure on yourselves as a couple, because if you put too much pressure on yourselves, then sometimes issues like erection or ejaculation, erectile dysfunction come into play, and that will make it more difficult for you to get pregnant. So every 2 days is fine. The other important factor is you've got to have intercourse before ovulation. So if a woman has a 28-day cycle, she normally ovulates 2 weeks beforehand. So she's ovulating around about day 13 or day 14. So basically, you want the sperm in the tube waiting for the egg to be released. So I would say if a woman's got a 28-day cycle, start having intercourse from day 9 or day 10 up to day 15. So there's sperm in the tube waiting for the egg. If a woman ovulates and there's no sperm there and it waits for the sperm to turn up, the chance of getting pregnant is probably about a quarter of what it would have been if the couple had had intercourse prior to ovulation. So the egg doesn't like to wait for the sperm, so you've got to have the sperm in the tube there, and every 2 days is fine. Now, for example, if a woman's got a 34-day cycle, she's normally ovulating 34 days minus 14 around about day 20. So start having intercourse about 5 days before you think that you're ovulating, and at least a day afterwards, and that will cover your options. Sometimes people use those urine predictor kits that you can get from the chemist, Clear Blue, Discovery, Serotech, those sort of things. They're very good. You test your urine from about 5 or 6 days out. They're a lot more accurate than the apps on the phone, but you start monitoring your cycle, and then you work out when ovulation occurs. But if you're using those apps, the important thing is basically they should tell you when to stop having intercourse, not when to start. So you've already started having intercourse, the kit goes positive, then you can sort of say, I'm going to ovulate in the next 24 hours, and then I can relax. I can take my foot off the pedal and take things easy. What you don't want to do is to do those kits, the test goes positive, and then you speak to your partner and say, okay, let's get started. It's too late. You already want to start having intercourse before the kits go positive. Catherine asks another question about how would you change management if someone's had 2 cycles with grade B blastocyst transfers and 2 biochemical pregnancies, both that miscarried. Well, I guess, Catherine, a couple of things that come into play is the age of the eggs that you're dealing with. The important thing in that sort of situation is that you're getting pregnant. So unfortunately, they're biochemical. It's not the end result that you want, but at least they're implanting, which says to me that probably the lining of your womb is good. and that's occurring. So again, I go back to square one and I'd sort of say, okay, I'd check the sperm out, make sure the sperm is good, and whether there are any fine-tuning that you can make there. It may be purely bad luck. You know, if you are a 38-year-old woman, then unfortunately when you get pregnant, the risk of miscarriages are probably about 1 in 3 pregnancies. So, you know, 1 in 3 times 1 in 3 is 1 in 9. So basically, you know, 10% of women who are 38, not that they've done anything wrong, unfortunately, may, heartbreakingly go through 2 miscarriages back to back. But you're having biochemical pregnancies, you're obviously getting the embryos to go back in and you're getting pregnant. So that's very, very positive. As far as the grading of embryos go, a little bit of information about that. We grade the embryos A, B and C depending on the trophectoderm, the cells around the outside that make the placenta, and the inner cell mass on the inside. So if they're at the full-grown blastocyst, they'll have a grade with 2 letters, AA, AB, BA, BB, BC, things like that. If you're getting a C grade embryo, then the quality of the embryos is probably not great. Most of our embryos are B grade embryos that we put back in. They need to be absolutely fantastic before the scientists give them a AA grade embryo. So don't be disillusioned by BB grade embryos. That's probably the vast majority of embryos that are there. As far as grading of embryos go, our scientists are highly trained and they're fantastic at telling you which embryos are not good. They're not worth freezing. They're not worth putting back into the embryo. So our negative predictive value is very high. So embryos that are not good, that won't work, we're very accurate at being able to tell you don't waste your time with them. Unfortunately, the converse is not true. So when you get a good grade embryo, we don't really know if it's going to work. All we know is that this is a good embryo. It can result in a pregnancy, put it back in, or if you've got surplus ones, freeze them. So to give you an idea, when we grow embryos in the laboratory, we grow them to day 5. The faster growing embryos give us higher pregnancy rates. But, over the years, I wish I had $50 for every time it was, someone did an IVF cycle and we put 1 embryo back in and they had 2 embryos or 3 embryos in the freezer. And it was actually the last embryo that was the one that implanted and resulted in the healthy baby. So, we've obviously graded the embryos. We think we're putting the better embryos back in first, and then as time goes on, putting the poorer quality embryos back in. But in actual fact, oftentimes it's the last embryo that may actually do the job. And so it just goes to show you that with grading, you need to take that with a grain of salt. One other question here about having an ectopic pregnancy. Had an ectopic pregnancy 9 years ago and then miscarried, and then had a successful pregnancy who is now her daughter 7 years ago, trying for a year. All the tests are normal. Husband's semen analysis is normal. Any advice? So basically, in that situation, probably the biggest factor is going to be related to the age of the egg and also working on one tube. We know that women that have had an ectopic pregnancy, even if the tube's not removed, if it's preserved or treated with methotrexate, it may not function as well. You can do ultrasounds and put fluid through the tubes and check to see that it's open. But the tube is a lot more complex than that. When a woman ovulates, it sweeps across the ovary with its little fingers. It picks the egg up, it draws it into the fallopian tube. It nourishes that embryo from the glandular secretions. It has fine little hairs that push the eggs and sperm together, and muscle, peristaltic muscle, within the wall that pushes the embryo down into the uterus. And with an ectopic pregnancy, the tube can be damaged. Even though it's open, it can be damaged. So oftentimes after an ectopic pregnancy, people definitely can still get pregnant naturally, but that other tube may not be working as well. So working on one tube, and then also the other factor of being older, 7 years older, that comes into play. Now, it really depends on the age. If you got pregnant when you're 25 and you're 32, age probably doesn't have a huge impact to play. But if you got pregnant when you were 34 and you're now 41, then obviously the age of the egg is probably the biggest factor that's coming into play. So depending on how long you've been trying for, AMH levels, egg numbers and things like that, then basically what I would do is you have a chat to your fertility specialist and then go from there. Obviously, in the event of an ectopic pregnancy, probably things like IVF is going to be better to bypass the tube rather than things like inseminations. Anyway, I will sign off. So just on that question, it's now 38. So yes, so certainly fertility does decline from when you're 31. You're super fertile when you in your early 30s, and unfortunately, it's sort of 35 to 37 fertility rates do decline. So even though things are normal, probably the age of the egg is one of those contributing factors, probably the most contributing factor. I will sign off because it's now sort of after 8 o'clock. I hope you've found it useful tonight. We try and put these information nights on to answer your questions and give you a bit of a insight into sort of what services we provide at IVF Australia. I hope you found it useful, and I appreciate your time, and enjoy the rest of the evening. Stay safe, and hopefully good luck with your fertility treatment in the future.